the lens cap. Okay, well, one of the things I'd like to talk about this morning is how proud I am about the character and the type of anesthesia that we use. I think we've heard a couple of questions. Certainly we heard last week, one of our patients is a physician. She's an ER doctor. And she actually was so nervous that she decided not to even ask about anesthesia. It was only her support person who then kind of whispered in my ear later that she is really frightened about the anesthesia and waking up and things like that. And then, of course, pain and going to sleep and all these things. So there are a bunch of topics that I'd like to talk about and kind of brag on the fact that we're using some really, really exciting new anesthetic techniques. And in fact, last year in Paris, I went and presented our new techniques to people around the world because we're so proud of them, and we've demonstrated that they've significantly decreased our patients' pain and discomfort while improving their ability to maintain their breathing and oxygen post-op, which can be a problem if you're heavy. So let's go into some background. First of all, we want you to go to sleep when you're having surgery. That's the theory, right? If you're going to have somebody, say, saw off the top of my hip bone and hammer in a new artificial titanium hip with a ball on the end that I'm going to walk on, I'd just as soon be asleep. You mentioned having local for that. During this, hearing the saw, I'd just as soon put me out. And there are two major classes of drugs that are commonly used in anesthesia, and I'd like to talk about them. And in a nice way, I'd like to kind of run them down a bit, say something slightly negative about them, point out some of their disadvantages, and then talk about how we modify the anesthesia we use to deal with those problems. So two big common kinds of medications that are used for anesthesia you've heard of. One's gas anesthetics. You breathe in the gas. And those of us that are old will actually remember ether. So when I had my tonsils out, there was a guy putting a big cone and they dripped ether on it and they said count back from 100, and I went 99 and I was out. Well, ether was great except for when you woke up you were screaming, that if there was a spark, ether exploded and could blow up the patient, the doctor, and the hospital. So gas anesthetics have advanced quite a bit, but gas anesthetics, which are still used in over 90% of all the surgery and anesthesia used in the country today and around the world today, have two major drawbacks. One is not deadly, but it's really unpleasant, and that is if you get a gas anesthetic, 1 person out of 3 when they wake up will have severe nausea and vomiting. They'll have retching. Just that from your toes, I'm sick and I'm vomiting kind of feeling. 1 person out of 3 using the gas anesthetics that we have today have post-operative nausea and vomiting. And I see a bobbing head there. Is that, yeah?
Yeah, we're your all 3, so everybody else should be fine.
Yeah. So we see then that one of the problems, and this is not deadly, but boy, the people who've had it talk about it, it's a terrible, unpleasant experience. And so the gas anesthetics, which have many benefits, which I'm not touching on as much, have this disadvantage. The other more deadly, dangerous, and serious disadvantage of the gas anesthetics is because they're lipid soluble. That is, you know, oil and water don't mix. Gas anesthetics dissolve in fat, dissolve in oil, and not in water. So it means that when you breathe them in, they go into the bloodstream, which is water, for just a second, and then they dissolve in the fatty tissue. And the side effect of that is when you wake up very quickly and safely from the gas anesthetics, but occasionally the fatty tissue can harbor enough of the gas so it can leak back into the bloodstream and depress your breathing. And if it does that after surgery and you're heavy and you have some lung disease already and you've had surgery, all of a sudden that list of complications can suddenly mean low oxygen, irregular heartbeat, and sometimes a real post-operative tragedy where the patient can have respiratory arrest or cardiac arrest or even a death. Now, it's pretty uncommon, but still, that's very serious. So we want to potentially avoid that in patients who already are heavy and having surgery and having an effect on their lungs. So gas anesthetics, wonderful, effective, very commonly used and dirt cheap, but postoperative nausea and vomiting and respiratory depression because of the lipophilic nature. So we don't use those drugs. We use something called propofol, which is an intravenous drug, and it doesn't stick around and it doesn't cause nausea, so we like that, and that helps us get rid of one of the drugs. Now, having talked all about gas anesthetics, I'm now going to talk about the other big drug in anesthesia, and that's narcotics. Because we don't want you to have pain. So in addition to the gas, during the surgery and after surgery, you'll get intravenous narcotics. Sounds great. Two problems. Number one, codeine. Anybody ever had codeine, get sick, nauseated from that? Narcotics work on the part of the brain called basically the receptor that causes you to throw up. Those chemicals that cause pain relief go right to the receptor in the brain that causes you to retch. So when we're giving pain relief to patients and we're giving them narcotics, oftentimes they get sick, just like if you take codeine. So we say, we want you to feel better, we want you to be out of pain because we sawed off and hammered in a new hip bone, and we give you a bunch of pain medicine, narcotics, and it helps with the pain, and you're retching. Well, I'm not having fun. On top of that, just like the gas anesthetics, there's an effect on breathing. And you probably have heard about this if you just think about it for a second. How do people die of an overdose of narcotics? They stop breathing. That is, narcotics decrease breathing. Gases decrease breathing. The combination, plus somebody who's heavy, plus anesthesia from the surgery, all of a sudden, again, you're dealing with somebody where you want to take away their pain, you want to give them narcotics, and all of a sudden they're not breathing because you've given them narcotics. Plus, they're nauseated from the gas anesthetics in a third of cases, and then you give them narcotics on top of that, all of a sudden you're retching and throwing up, and now you've got an unpleasant experience. So those are two foundational drugs, and we like the narcotics, but we'd like to avoid them as much as possible. So we want to talk to you for a second about narcotics in general. What are narcotics? They're a chemical that goes to some place in your brain and takes away pain. And they're great, but have some side effects. Well, what if we could find other places in the brain? Is that the only place in the brain that affects pain? So they've got a whole area of research called opioid sparing, analgesia, and anesthesia. Opioids are narcotics. Sparing means we don't want to take them away from you, but let's use less. Because if I can give you half the dose, oftentimes there's no nausea. And analgesia is pain relief, and anesthesia is anesthesia. So we are going to talk to you about a hot new area of research where we say, let's look for medicines that we can give to patients when they're having surgery and decrease nausea and vomiting, decrease respiratory depression, get rid of gas anesthetics, and decrease our need for narcotics, and we do all those things. And this is new since you guys were here.
Is that the current procedure that you put into practice?
Right, and it's about 2 years old, and basically what we did is prior to using the technique we use now, we used Tiva, which is narcotics, and propofol, but now we're better than Tiva. We found two areas in the brain. One is called the N-methyl-D-aspartate receptor, or to make it easier for the rest of this discussion, NMDA receptor, and the alpha-2 receptors in the brain. And what we found is if you give mice a little foot shock and bother them, we can give them different medicines and test if we can take away their pain. And then we can go and give them to patients in a double-blind trial and see if we get less pain and more happiness with their opinion about the surgery. And we've done that here and shown that by adding in a mix of other drugs affecting NMDA and alpha-2, we can give you less pain, We still have narcotics for you, but you'll need less, and they work better. So let me list some of the drugs you're going to get, and I'm going to start off by giving you one that will hopefully get your attention. Melatonin. Right? In other words, they took women who were going to have a hysterectomy. Half of them got melatonin, half got a sugar pill. The ones who got melatonin needed less narcotics, had less pain, and felt better about their anesthesia. So our patients, we're going to recommend tonight, take some melatonin. Ketamine. Ketamine's an old-timey drug. It's got some interesting benefits because it helps support your blood pressure. It stimulates breathing, doesn't depress breathing, and it helps pain relief. Plus, it makes depressed people happy. So they took people who were depressed, come into the ER, and they can't give them Prozac because it takes 2 weeks for the Prozac to kick in. So they wanted, could we find a drug that makes people antidepressed quickly? And they found they got people who are depressed. They filled out a depression scale. Are you sad? Does life look like it's bad? All these things. They gave them, started a drip of intravenous ketamine. Within 10 minutes, their mood began to lighten, and it stayed elevated for a week. So low-dose ketamine is now part of our anesthetic technique, and now my life is easier because I have happier patients post-op. They fuss at me less. Now, ketamine's well known for having another side effect. Sometimes you can have bad dreams and confusion and things like that. And what they found is, by using a lower dose, it works great. It helps protect you from that. Although you occasionally get a bad dream or think you see Uncle Smithy visiting you in the post-operative period, but it's okay. So ketamine's an old drug which has been shown to be an opioid-sparing drug. We also use another drug that's brand new, only a year or two old, and it's called dexmedetomidine, or Precedex. And Precedex is a drug which works on the alpha-2 receptor, and again, decreases pain without inhibiting breathing very much. So you get a combination of drugs, melatonin, gabapentin, ketamine, Precedex, all as a mix, and what we found is, number one, less pain, that's our goal. Much less nausea and vomiting. Great. Much more enjoyment of the anesthesia itself, like you saw the people here this morning. There wasn't anybody fussing about it or having an unpleasant experience. And good long-term pain relief. And so we think you're really going to like it. Now there's one more topic that people often want to talk about or they don't want to talk about, but it's bothering them, and that's I'm frightened, Dr. Rutledge, that I might wake up during anesthesia. And so there's that kind of fear. Maybe, did you see the movie? You know, I was worried about that. And we want to tell you a couple of things. One is that we monitor your EEG. And when you're wide awake, your EEG looks like this. And you know, when you pass away, it's flat. And we can turn it down so that you're asleep. And so we monitor that every minute to keep you asleep. The second thing is, if you were to wake up and be paralyzed so you couldn't tell anybody, that's the real tragedy, because somebody is operating on you and you can't tell them. We don't use paralysis, so we say, and this is a joke, it's being facetious, so sometimes people mistake my kidding around as serious, but since you're not paralyzed, if you wake up and you notice I'm operating on you, just tap me on the shoulder and say you'd like some more medicine. But the scary thing, I think, would be to have major surgery to wake up and be paralyzed so you couldn't communicate to the doctor. So in our case, we don't use paralysis, so if that were to ever happen, which it never has, but you could always just, you know, say, hey, by the way.
It's very a quick time window. It's not like you're on the table for 6, 8, 12 hours.
Exactly right. Yeah, that's the other thing. The surgery being so short, there's some other advantages because the amount of drugs that you need is less. Because we're not cutting and traumatizing the abdomen as much, there's much less pain. And also because there's very little blood loss, there's also much less pain. So we had a patient today with a real serious problem, that's her neck pain. But we asked her about the surgery that I did, she had no pain at all. And so we hope and pray that we can offer you that same experience, a good anesthetic experience where basically you ask them about it, they go, I have nothing to say because nothing as far as they know ever happened. There's very little pain post-operatively, and in general, give you kind of, in general, kind of a positive feeling because of the combination of medicines that don't cause nausea and don't cause these other problems. So, does that touch on any of the things that you were interested in, or is there anything more that I can go into to talk about the anesthesia at all? Anything else special on it? No. Any other things on the anesthesia that, does that give you kind of an overview at all? Do you feel?
That helps a lot.
Okay. I think you're going to have a good experience. Again, in the past, I was a regular general surgeon, so does that make me an irregular surgeon? But I did all kinds of things. Now, if you think about it, I only do one thing. I only worry about one thing, morning, noon, and night, and that's doing the MGB as smoothly, as simply, as safely, as painlessly as possible. And I think, you had a good example here. You have 3 people from last week, and what I heard is one person has some neck pain, but she had neck pain before, and otherwise I didn't hear much about the surgery being bothersome to them at all. And that's what we hope and pray and expect in your case as well. Other anesthesia questions? Did I do an okay job in explaining what we do?
Oh, yeah, I had no questions to start with. I have a question, but it doesn't have to do with it.
Okay, well good. Let me finish up this then. Good.
Okay.